It's critical that all Kenyans register. We need to really talk about that, and including the informal setting, because we see the formal setting are onboarding, but then informal, again, there's a bit of slowness. And so what we are doing is really working together with the community health promoters. So again, at county level, you know, implementation health is devolved. So the governors and the CEC, the teams for health within the county, and again, the community health promoters. And really, I must talk about the community health promoters. They have been able to visit 8.5 million homes out of the 12.5 million households in Kenya. And they've been able to diagnose more than 330 cases of diabetes and more than 331,000 cases of diabetes and more than 700,000 cases of hypertension. Equally being able to pick 134,000 mothers and taking them to facilities for care. And more than 6.9 children have been assessed under the community health program. So great work is ongoing. There's good coverage, and we are leveraging on this platform, that is the community health promoters, to ensure that they are informed, that they are assisting in a registry of patients, and also supporting them in order that they can contribute.
Okay. Now, according to the Project Consortium agreement, Apeiro will receive 57 billion shillings, Safaricom 21 billion shillings, and Convergence 17.2 billion shillings. Can you break it down for us? What exactly are their defined roles?
Okay. Now, that is an operational question, and it would go directly to the PS Medical Services, because each one of them was given a responsibility. Some of them were working on the SHA, e-claims portal, the SHA portal, and others were working on the registry, the health workers, and there was another team that was working on the patient journey. And so I apologize, I don't have those details,
okay,
but given a chance, I can answer them.
Let's now talk about the funding cuts and how this has impacted Kenya in general and the health service. Now, of course, we're still reeling from USAID freeze. HIV mitigation programs, TB were some of those affected. How are we compensating for that as a country? And what is the extent of that implication of the aid freeze?
Yes, now I want to assure Kenyans that they are commodities at facility level. Tomorrow, Ashley, I hope you can join me. We're going to MEDS together with KEMRI colleagues and USG government representatives. And what we're going to do is, again, flag off medicines, flag off ARVs, anti-malarials, anti-TBs, among other medicines and commodities, so that they can reach facilities. And what I want to assure Kenyans is that for the next 8 to 9 months, we have medicines for Kenyans. Now, what are we doing thereafter? Because yes, they might continue lifting up, or again, they might pause. So as a ministry, we have sat in, and actually today we were with the development partners, sharing with them, seeing how they can support. Yesterday we were with the Council of Governors, together with the representatives from Treasury, and again the program officers and technical officers, and what the PS and the DG, and what we were discussing is how can governors implement. We have established, we've come up with a report, and in that report we are talking about the impact. We are talking about the resources that we need in matters human resource, in matters commodities. We actually even had, they had established a digital platform for various programs. So how do we integrate that into our digital health system, so that we have, integration and under one broader health system, which is Taifa Care. So those are discussions that are ongoing. We are sharing with Treasury. We have developed a CAB memo to share with the Cabinet. Again, for Treasury, we want to ensure that we are securing funds which will incorporate to support the commodities and also the programs that were being supported by USG. And what we are assuring Kenyans is we are working tirelessly, okay, to ensure that we will not have a gap during this transition.
So this is within the 8 to 9 months, right?
8 to 9 months, we are comfortable.
Then afterwards, what happens?
Afterwards, that's where we are now securing funds from Treasury to support for the program to continue. But again, working towards integration of the program. What we are saying, we need one team, one plan, one budget, and one M&D. We've had fragmented, duplicated programs. Let me give you an example. Like for our HIV program, you have a truck with a driver. They come and take ARVs and they take to a facility. Then another truck with a driver takes anti-TBs and then takes to a facility. And another one, anti-malarials, to a facility. And these the partners are also in different counties. So you find that it's fragmented. But when we have it integrated and it's one, what does that mean? You can just have one truck and take all these medicines, all these commodities, and transport them, you see? So we have not had that, and that has led to inefficiencies. It has led to, it's not cost effective. It has led to loss of a lot of resources. And again, duplication, because anyway, a HIV patient can also have malaria, diabetes, TB. Does it mean that they go to another facility, you see? So it's all about integrating everything into one health system.
You did mention that it's a blessing in disguise. It's high time we depend on ourselves. But how possible is it? And it's all about effecting it and implementation. Because so many people say Kenya is not short of ideas. The problem is implementation. So when you look at the long-term plan, when it comes to